Hi everyone, my name is Vasu Malhotra and I'm a PGY1 internal medicine resident at Lakeland Regional Health. I'm super excited to present this fascinating case titled From Coccyx Pain to Neurological Impairment, Investigating a Case of Pachymeningeal Enhancement. This case represents not just a diagnostic challenge but also a valuable teaching opportunity. It's rare to encounter a condition like pachymeningitis and even rarer for it to present in such an unusual way. Today I hope to shed light on the mechanisms, challenges, and learning points this case brings to internal medicine. Pachymeningeal enhancement is an imaging finding that reflects inflammation or infiltration of the dura mater, the thick outer layer of the meninges. While rare, it can result from a wide range of conditions including infections, autoimmune diseases, cancers, and even idiopathic processes. Clinically, it's like a chameleon. It can present as headaches, cranial nerve deficits, or as in this case with progressive neurological symptoms. What makes this case particularly unique is the initial presentation of coccyx pain and constipation, which evolved over several weeks into profound neurological deficits. This atypical onset not only delayed the diagnosis, but also highlights the need to think broadly when symptoms don't neatly fit into a single diagnosis. The patient is a 35-year-old woman with a history of polycystic ovarian syndrome and hyperlipidemia, who presented initially with progressive coccyx pain and constipation. She was diagnosed with coccydynia and sent home with symptomatic treatment. Over the next month, however, her symptoms escalated dramatically. By her fourth visit to the emergency department, she had developed bilateral lower extremity weakness, numbness extending to the buttocks, multiple falls, and even bladder and bowel incontinence. During her admission, things got more concerning. She developed fever, delirium, and leukocytosis, classically raising concern for sepsis. But imaging, including CT scans of her thoracic and lumbar spine, showed no abnormalities. Here's where MRI became pivotal. It revealed diffuse pachymeningeal and leptomeningeal thickening extending from T8 to the sacral region with basal meningitis and mild communicating hydrocephalus. This finding completely shifted the differential diagnosis, pointing us towards inflammatory or infiltrative conditions affecting the dura. One of the most striking aspects of this case was the difficulty obtaining cerebrospinal fluid due to the severe leptomeningeal thickening. Despite these limitations, the small sample we obtained revealed marked neutrophilic pleocytosis, but no definitive answers. At this point, we turned to additional tests. Infectious workup, including HIV and tuberculosis testing, was negative. Serum angiotensin-converting enzyme levels, commonly elevated in sarcoidosis, were normal, but autoimmune screening revealed strongly positive anti-nuclear antibody and markedly elevated inflammatory markers. Here's an interesting clue. The patient also developed tender erythematous nodules on her legs, consistent with erythema nodosum, a finding often associated with sarcoidosis. Yet, without a leptomeningeal biopsy to confirm non-caseating granulomas, diagnosing neuropsychosis remained challenging. Another possibility in our differential was IgG4-related disease. This condition can also cause hypertrophic pachymeningitis, but diagnosis hinges on elevated serum IgG4 levels and biopsy evidence of IgG4 positive plasma cells. Unfortunately, neither IgG4 testing nor a biopsy was performed in this case, highlighting a key limitation in our workup. So what can we learn? Let's break down the key takeaways from this case. The initial presentation matters. The early coccyx pain might seem unusual, but it could represent irritation of the sacral nerve roots caused by leptomeningeal inflammation. This reinforces the need to connect localized pain with systemic signs when symptoms escalate. Diagnostic challenges. CSF analysis is often limited in cases of pachymeningitis, especially when thickened dura obstructs fluid collection. While MRI findings can guide the differential, a leptomeningeal biopsy remains the gold standard for diagnosing conditions like neurosarcoidosis and IgG4-related disease. Future tools like next-generation sequencing of CSF or serum cytokine assays may reduce reliance on invasive testing. Neurosarcoidosis versus IgG4-related disease. While both conditions can present similarly, they require distinct treatments. Neurosarcoidosis is typically granulomatous, while IgG4-related disease is characterized by fibrosis and IgG4-positive plasma cells. Recognizing these patterns is crucial for initiating the right steroid-sparing agents like mycophenolate or methotrexate early in the disease course. This case reminds us why rare diseases like neurosarcoidosis and IgG4-related disease require a broad multidisciplinary approach. It's a perfect teaching case not just for identifying unusual presentations, but also for overcoming diagnostic barriers with evolving tools and targeted therapies. Thank you for your time.